Hello everyone. Welcome to tonight's workshop by Dr. Lay of the Gender Confirmation Center, as well as a panel discussion by two individuals who have had various forms of transmasculine bottom surgery. This workshop is the second educational peer support session to be provided by the Navigating Gender Together, a program operated by Trans Emotion, which is a trans-led and trans-serving organization here in the Central Valley. Navigating Gender Together is a program coordinated by me and which offers free gender-affirming garments such as binders, gasks, packers, shapewear, and breast forms to people who live in the Central Valley of California. And I just realized I haven't introduced myself. My name is Ari and my pronouns are he, him, and I am the chair of Trans Emotion, and I am also the program coordinator for Navigating Gender Together. This program also hosts support to trans folks in the form of online peer support sessions, including this one. Everything that this program is doing and will continue to do has been made possible by a grant from the California Department of Public Health. If you are interested in applying for a free gender-affirming garment or subscribing to our emails, you can be the first to know about our future educational sessions like this one by signing up for our emails at our website, transemotion.com. And I'm going to take a second to put that link in the chat. This session is just the second installment in an ongoing series of workshops and panel discussions facilitated by a trans person and intended for the trans community. Our guest speakers will include trans people and/or health professionals who specialize in our health. Please note that you will have the opportunity at the end of this workshop and before the panel discussion to ask Dr. Lay any questions you have that weren't answered by her presentation. You can drop those questions in the chat anytime, and I will voice them anonymously on your behalf at the conclusion of Dr. Lay's presentation. Or once the Q&A begins, I will allow you all to raise your hands, and I can then unmute you, and you can ask your questions aloud. And now I will introduce Dr. Lay, a board-certified plastic surgeon considered an expert in all aspects of transgender and gender-diverse surgical care. Dr. Lay is the only transgender woman of color to offer a full-spectrum specialization in gender-affirming surgery, top surgery, bottom surgery, facial surgery, and body contouring. Prior to joining the Gender Confirmation Center in 2022, she worked as an assistant clinical instructor of plastic surgery at the University of Utah and had their own private practice in Arizona. So welcome to the virtual stage, Dr. Lay. We are so honored to have you here with us tonight. Are you ready to get going? Oh, you're on mute. Sorry.
Hi, everyone. Thank you. Oh, my dog. Um, Sorry, I just came off another call from my office. But hi, everybody. Thank you for taking time this evening to join in this talk. We're talking about transmasculine bottom surgery, correct?
Yes, we are. And I'm sorry, before you get going, I actually also forgot to introduce Justine. Justine is here from the Transgender Strategy Center to help support this program. And if there's at any point I'm not able to be in the room, if I had to run out of the room for something, Justine will step in and will take over for me. So just want to introduce Justine and thank you, Justine, for being here to help back me up at this event. Okay, now go ahead, Dr. Lay. Sorry.
Okay. I'm trying to pull up the my talk. Um, I'm so sorry.
No worries. Take your time.
Okay. I'm not the most tech savvy person. Um, I'm gonna try to share the screen. Did that work?
I don't
No,
see anything yet.
mhm.
Oh, now there it goes.
Yes.
Okay. Um, and please remind me, how much time do I have?
You have up to 1 hour.
Okay. These talks, especially for bottom surgery, it just takes a lot because it's so heavy in material. So I'll try to respect the time and go through some of these things kind of fast. I'll kind of skip this part, but basically, Arian's already introduced me, and it just sort of says kind of how privileged I am to be unique in this field, and that I am one of the few trans surgeons, anyway, not transgender providers, to be clear. But within the surgery world, yeah. That's made me very unique, and my educational background has kind of played into how I basically landed a job in gender surgery. I can tell that story later, but it had to do with my transition and looking for surgery, and I ended up with surgery and a job. Um, so so today, I'm going to cover basically how to get through consultations, and these kind of basic concepts can be applied to any kind of uh, surgery consultation, especially related to gender. And then I'll go on to preparing for surgery and give an overview of like the basic concepts and the bottom surgery options that I offer. Um, and then also talk about some non-binary slash gender neutral options. Of course, the gender team is a multidisciplinary approach with mental health providers, medical providers, and surgical health, which is where I come in. Now, when it comes to surgery, bottom surgery especially, you have to do your research and make sure you go to someone who is board certified or at least eligible for board certification, which means that they are new graduates from training, whether it's plastic surgery from gender surgery fellowship type of situation. It means that you're a full-fledged surgeon, and it takes, I think, less than a year to become board certified once you meet all the qualifications and pass the exams. So you want to go to a recognized and certified surgeon. And in gender surgery, there are different specialties that are qualified to do these surgeries. So plastic surgery, which is where I come from, but there are urologists that are experts in gender surgery, gynecologists, urogynecologist, which is like another sort of subspecialty within the OB-GYN field. And depending on the situation, you may find some general surgeons offering this, although it's likely it's not sort of likely or common to have someone do that. So maybe some top surgeries or something like that. But as long as they have the proper training, especially when it comes to gender surgery procedures specifically. And I put on here not cosmetic surgery because the title of being a cosmetic surgeon um, can be sort of thrown out there or obtained by like non-surgeons. I have seen ads of like liposuction experts, and when you really look into it, they're a radiologist. You're like, wait, like what? Like, how is that? So anyway, be careful about who you choose and make sure you check credentials. Now, of course, what are we treating with gender surgery? Of course, gender dysphoria. Um, as most of you in this presentation, as well as myself, we very well understand what gender dysphoria is, but it affects all of us, and we all have our own unique journey. So, like, where do we start? So usually, and this is the way that I personally started my journey into like, okay, I know what I am, but now like what can I do about it? How can I get help? And so I, of course, reached out to the internet, but you have to be careful with the internet as well, because there is very good information, but there's also misinformation. Um, so just watch out for that. Usually, like academic centers have good information. Major gender surgery centers have good information. And when it comes to Reddit, there is also very good information, but it's when things get a little trickier because then a lot of people have opinions about a lot of things. And so, just be careful with that. And so do your research, talk to others. There are resources for getting information, accurate information. Your other providers can also help you um, with recommendations and things like that. But there are other things, not just like, how to figure out where to go, how to start. But then when it comes to like taking action, there are considerations such as like, well, especially now, like where are you? And again, especially for trans youth, like where can I get surgery where it's legal, right? So geographic location matters. If someone is in a very rural area, it may be very hard to seek hormone therapy, electrolysis, um, and even just normal general health care that is, gender friendly. So, um, and then of course there's costs related to all of these things that we also have to consider. That some people can't go very far and things like that, or can't figure out their post-op care. So there's a lot of this that can happen. Like our office in particular, and I'm sure a lot of the other major centers um, have references or resources, especially here in California and in the Bay Area, for lower cost places to stay, but also places that help you recover. But the sort of like the space for that is very, very limited. So it requires planning like, you know, quite a bit ahead of time. So um, there are such resources for that. Oh, come on. Uh-oh, sorry. All right. So the other thing going into the actual surgical consultation, I always recommend that patients look at multiple centers and actually make appointments if they are able to. Now, this can depend on who's in network with the insurance. And again, it also goes back to location and your ability to go to these places. Many places offer virtual consultations, and other places require in-person, ultimately an in-person visit in order to proceed with surgery. So find out all of those things. And the best thing, and what I like is when patients come in and they have a list of questions um, that they want to ask. And sometimes, what I tell patients is don't be afraid to ask the surgeons like what your complication rate is. I'm pretty transparent about that. And things like that. So, and or how many of these have you done, or how long have I still get asked that, even though I'm slowly starting to become one of the older gender surgeons in the field now, although I'm kind of young, but I'm old. But anyway, so come in prepared, have the questions ready. And I think you'll get a lot more from the consultation by doing some of this research ahead and asking the questions. So So what I like to convey in the consultation, even if it's like a virtual consultation, is um basically for each procedure, like how I do the procedure, um, what are the goals, right? What am I making? A phallus? I'm making, like urethral reconstruction. We're talking about testicular implants, or any of the procedures. I tell patients kind of how I sorry, the trains pass away, um, how I do the procedure, what to expect uh, from having the procedure, what the recovery is like, drains, catheters, things like that. But the other thing I do talk about as well is potential complications, major complications, minor complications. Um, and then, of course, the our website as well. And this is the one part where I don't get too much into it in a consultation because of the limited time. It's a lot of the sort of the the information related to or what medications I might get after. We have a team of PAs and PCs, patient coordinators, and also things on our website that talk about how to care for the drain rather than, oh, you're gonna have a drain. I don't want to get into like, oh, this is how you treat the drain, right? Things like that. So, but we do have all of that information. But I do go over all of that. And one of the things that I think that I've done most recently, if any of you have had a consultation with me recently, is that there is um, such a thing as regret. And so I do mention that. And I also tell patients that basically all of our procedures are irreversible in the sense that I can't, make it back the way it was in terms of, original. But there are ways to reconstruct it, but it's complicated. And so I do bring that up now, and maybe it's a medical legal thing, especially in today's climate. But just know that I'm not saying it specifically to any person, or that I'm saying like, oh, like, I don't believe that you are who you say you are. It's not that kind of thing. So, but I do bring it up because it's something that's not only on the paperwork, right, and the informed consent, but I want to just like bring it up and let patients know. Now, the onto the procedures. So once you have decided on either a specific procedure or you're in between a couple procedures, those are again things to ask of like, okay, what are the pros and cons of this procedure versus having like simple metodioplasty versus metodioplasty with urethral lengthening. Um, and so that's great, that you're seeking more information about that. So, but some folks come in with a very specific set of procedures. But these are the things that I offer. Simple metodioplasty with urethral lengthening. I offered different types of phalloplasty, and I'll go into more detail, but pedicle phalloplasty and then microsurgical phalloplasty, and then scrotoplasty for those who would like to go down that path or add that to some of the procedures. And those that have gone through phalloplasty, then placement of an erectile device is another procedure that I offer. Now we're talking specifically bottom surgery, so I list these things. But one thing that may be recommended is something like a Mons resection that plays into um, improving or setting up sort of the bottom region uh, up for success for some of these surgeries. Um, Now with bottom surgery, there's a wide range of options. I actually have a flow chart, which I don't have it here. I'm trying to make it more simple, but um, it's basically a flow chart, and it's sort of daunting and confusing, like when I flash it up, because there's arrows pointing everywhere because there's so many pathways. It's very different from the trans feminine patients where for the most part it's basically vaginoplasty or vulvoplasty and some orchiectomies, right? Relatively simple, but with transmasculine, there's a lot of options of um, meta with vaginectomy, meta with scrotoplasty, but no implants. Um, you know, a lot of different combinations and a lot of staging, and some of these procedures can take, um, couple years or more to finish. Well, here it is. It's actually here. But you see, there's just arrows going everywhere because there's so many choices and so many paths that can be taken depending on what each patient wants to have. And so it's my job to kind of guide the patients um, as to, like, these are your choices, like, and I go through them. And then sometimes at the end of the consultation, um, I don't need an answer right away. I don't have to be like, okay, well, you got to make up your mind now. Um, you know, there can be follow-up consultations. Patients kind of think about the options I presented, the risks that I presented, and then they come back and we have a follow-up consultation, and then we narrow down the specifics of the procedure that you are looking for. And then we can really have a true surgical plan, but also a timeline, right? A timeline as to how long is it going to take to go through these procedures. So starting with relatively simple to the more complex procedures, I'll go through them. So simple metoidioplasty, it's nothing's really simple in gender surgery, but it is, I guess, relatively it's a safe procedure, low complication risk, um, much easier recovery than, say, microsurgical phalloplasty, right? So, but what is the goal of a metoidioplasty, and what is it that is accomplished? The easiest way to put it is that I want to tubularize your phallus, release it from tethering structures and tubularize it so that there's a distinct shaft and a glans that is exposed. Now, much of this depends on patients who are taking testosterone, right? Not everybody is on it, but those who are on testosterone and they've taken it long enough, 1 year, 2 years, or even more, there should be, not always, there should be a response in the tissues where the glans grows, the shaft grows. And so the more growth someone has, then the once I perform a simple metoidioplasty, the results are they're not better. They're just it can accomplish um, you know, more distinct tubularization and potentially show of the new phallus. Now, the structures that get released are the suspensory ligament, although that one, it really depends on the anatomy of the patient and whether I think that will add to length or not just the length. It may not add length, but if it helps to show the genitals, meaning making it more visible without like significant retraction or any retraction, then I go ahead and do it and tack some of the dorsal shaft skin down to the area of the ligament or the pubic symphysis. The ventral chordae is on the underside, and that's, I think, like the main structure that's keeping it in that down position. So that gets avoided in all the cases of simple metoidoplasty. When it comes to girth, some of this has to do with whether patients want to have the labia minora resected or preserved. It is an option. And so whenever I offer simple metodioplasty, one of the flowchart sort of options is labia minora resection or preservation. If I preserve it, I still have to cut through some of it in order to do the metodioplasty. But I don't have to cut it off. Some places do it automatically and they just assume patients don't want it. But many years ago, I discovered that, gosh, like I don't have to cut them off, and it should be the patient's choice to do it. And it took one patient to tell me, I want it preserved. And after that, I was like, oh my gosh, like it is an option, and it should be an option. And I've actually had more patients ask for that now. And so if patients want it, then I can't use it to try to add girth to the shaft. Now, even for those who don't want their labia minora, depending on the size of it and how sort of meaty it is, I may or may not be able to add a little bit of girth to the shaft. If they're too small or too thin, by the time I deskin it, it's called de-epithelialization. By the time I deskin it, because you can't just bury skin underneath the tissue, it's like basically like Swiss cheese, right? If it's really small, by the time I deskin it, it's basically unusable. But if they're meaty, then it's better. But that's an option to consider. Um, the other thing too is that simple metodioplasty has no urological um, procedures done. So patients who undergo simple metodioplasty simply pee through their original um, urethra. Um, yeah. So like I said, it's kind of all the things I said. Once the simple metodioplasty done and patients are healed, there is an option for patients to pump or use other techniques to try to lengthen um, the uh, the phallus. Um, and we can kind of give you suggestions for that. We don't sell the pumps. The medical pumps are like super expensive, but honestly, a good pump from like a novelty store works just as well. And there are other things like hanging weights and things like that. But those are options, and it can be successful. Now, again, more arrows. You can see simple meteoroplasty is not that simple. Other things that can be added to this is scrotoplasty, right? Simple meteoroplasty and scrotoplasty. And of course, from there, you can go to implants if you want. But vaginectomy is also an option with simple metoidoplasty for those who have had a hysterectomy, right? Because you can't get a vaginectomy without a hysterectomy. Um, so that's another consideration. Okay, I do show some surgery pictures. Obviously, this patient was in surgery. This is a simple metoidoplasty on a patient who had a very good response to testosterone. Um, and you can see, right, I think I met my goal of tubularizing and, making the penis shaft-like. Another question that gets asked a lot is whether um, I do a circumcised look and an uncircumcised look. Um, and the basic answer to that, it's a little more complicated, but is basically a circumcised look. But depending on the patient and how much sort of skin is there, um, how much it pulls out, that kind of thing. There are patients that get kind of a uncircumcised look, but it's not like it's true foreskin. It's just that when it's not erect, it kind of goes down and gets tucked in underneath the skin, and the skin rolls over it. Um, I'm not sure if I have a picture of what that looks like. But this is a good result, I feel. Um, And you see that divot there? That little, it's not a hole, it's a divot. That's where I released the suspensory ligament in this patient specifically, and I tacked the skin down. Otherwise it tense up and it sort of blurs out or blunts the top of the shaft in terms of like the shaft-like structure of it. So oh, here's one that's also another metodioplasty, simple metodioplasty, who had, very good response, but they wanted to preserve the labia minora. And yes, I do. Again, I have to cut through them, through part of it in order to do the procedure, but then I can kind of reconstruct it, put it back together so that it actually ends up looking quite normal. Now, the the glued incision lines along each side, that is for reduction of this like upper portion of the labia majora. Again, for the sake of reducing that sort of fullness that's adjacent to the shaft and allowing more show, more genital show. Um, but this is the patient that I referred to many years ago that asked me to keep uh, the labia minora and to put it back together. And since then, that's when I realized that, I should be asking patients what they want to do with that. All right, next level up, metodioplasty with primary urethral lengthening. It's a big step up from simple metodioplasty, only because the urethral lengthening is where most of the complications um, of this procedure comes from. Um, there's a sort of a classic paper of metodioplasty with urethral lengthening with or without vaginectomy. And the basic takeaway is that without the vaginectomy, which I personally require my patients to get a vaginectomy before I do urethral lengthening. There are centers out there that will do it without the vaginectomy, a metoidoplasty with urethral lengthening. And I'm happy to refer you to someone or a center where they might consider doing that. But I've talked to some of the gender surgeons, transmasculine bottom gender surgeons here in the Bay Area, and although they say they would do it, they've told me from surgeon to surgeon that they highly discourage those patients from getting it because of the complications. Now, I don't offer it without vaginectomy because I don't want to put the patients through the increased complications and then for me to have to deal with the complications as well. So I only do it with the vaginectomy. Now, the vaginectomy itself, I do it. I was trained to do it by a gynecologist, rest in peace. Um, he did pass away. He helped us do these procedures in Arizona when I was at the Meltzer Clinic. So um, he taught me how to do it. Now, vaginectomies, the other question to ask about vaginectomies is basically to the surgeon, like how do you do it? So I do it by actual resection of the vaginal lining. rather than fulguration or burning. Some surgeons do a combination of excision, especially of the more superficial portion of the vaginal canal, and the deeper part, which is harder to get to and harder to work with, and a little riskier to do. They will fulgurate, meaning they burn the lining. So I do it with excision. I think that it is recognized that with excision, granted that the excision is done well, that the risk of ending up with pelvic mucus cysts is lower than in fulguration. So what fulguration means is that you have to burn through the thickness of the vaginal lining, and it actually has a thickness that can be seen. Like when I do this, it comes out as a kind of a thick sheet. And so that burning has to be fairly even through the entire surface of the vaginal canal, so that maybe the surface gets burned and the deeper portion of the actual vaginal lining doesn't. And once it's closed up, that vaginectomy site is closed up, it can potentially turn into a pelvic mucus cyst. If they're small, I don't think they're symptomatic and there's nothing to do about it. But I've spoken to other surgeons where they have had to deal with these and basically go back in and kind of carve it out. So I do it by excision. Um, Now, one of the main reasons why patients choose the urethral lengthening is that they want the opportunity to be able to stand to void, right? To stand to pee. And I say opportunity because it really depends on the patient's anatomy. Now, the obvious thing is that if patients have had very good response to testosterone, then, their penis is, um, larger, longer, so that when I extend the urethra, it goes to the tip on everybody, but then it can clear, I sort of call it can clear the zipper better if it pulls out. Sometimes if someone is on the heavier side, there's a lot of tissue that gets in the way, and therefore, like you saw in that patient with a labia minora, that you can do procedures to reduce that adjacent tissue, again, for more genital show. Or do a mons resection where the mons is reduced, but then everything's pulled in a superior position so that the whole sort of pubic region gets pulled up and out, if you can picture that. Recovery is much more involved than a simple metoroplasty. You will have a suprapubic tube, which is a catheter that goes directly through your abdominal wall into your bladder, and you basically pee into a bag for a minimum of 2 weeks. And that's kind of your safety net in terms of your voiding. Your new urethra will have a Foley catheter through it, but you're not peeing from it. It's basically just kind of holding the space open so that the new urethra heals and doesn't just collapse on itself and shut down. That gets taken out usually about 10 to 12 days after surgery. And then for the first time, you get to pee 10 to 12 days after surgery. And as long as you don't have a, as long as you don't have a, as long as you don't have any complications, wound breakdown, or fistula, then the suprapubic tube can come out. But if there's any urological issues, that suprapubic may end up staying anywhere from, several more weeks to even several months, depending on what's happening. This is actually a picture of, see what I mean by the uncircumcised look? This is a good example of that, where the skin kind of folds over. And obviously the patient has had scrotoplasty. These are some penile stretching techniques. Aside from the pump, I don't have a picture of the penis pump. Um, so scrotoplasty, there are different techniques of doing it. I'm considering adding other techniques, but for now, I basically use a scrotal flap, a superiorly based scrotal flap. And I tell patients I kind of do skin origami to kind of use those flaps to create scrotal sac, and in the process, be able to lengthen the patient's perineum. So the perineum is a space basically just above the anus, right? Sometimes it's called the taint, right? It's kind of the street name for it, I guess. I actually don't like that name because it makes it seem so gross. Um, but um, but anyway, that's called the perineum. And so by doing the scrotoplasty, especially if the patient has had a vaginectomy, then that length between the base of the scrotum and the top of the anal ring um, is lengthened, which is a masculine, you know, anatomical feature.
Dr. Lay, I just want to let you know you have 15 more minutes.
Oh my goodness. So testicular, so scrotal expansion may be needed depending on how the scrotoplasty comes out and what the patient's wishes are in terms of the size of the testicles, right? Um, and the testicular implants, these are just how the testicular expansion happens. The picture on the left is at the max, the patient has achieved the goal of expanding the scrotum. And it's always overexpanded because once you take it out, the tissue shrinks easily 20%. Um, and so it's overexpanded and then it gets replaced with testicular implants. So this is a typical look after expansion. And again, there's those adjacent labia majora cuts on the side. Of course, they're no longer labia majora, it's a scrotum at this point. These are just examples. Scrotoplasty complications is basically wound dehiscence is probably the main one. I don't do scrotoplasty and then put an implant in it at the same time. That has to heal for 3, 4, 5 months, depending on how things are healing. And if it's adequate and they can go on to a smaller testicular implant, then I'll do it without the expansion. Again, just like the penis can be stretched out for size, the scrotum can also be stretched out so that it's more sac-like and it can hang a little bit more. All right, going on to phalloplasties. Pedicle flaps means that it's not completely detached, that the blood supply is still attached to a portion of it. And so a groin flap is one of those flaps that I offer. It comes obviously from the groin, just above the groin crease. And it has, it's typically creates a good size phallus, good girth. The glands, once it goes through the process of the divisions of the flap, the glands can be shaped so that it looks more natural. But the flap, the bad thing about the flap is that it doesn't have any erogenous sensation. Eventually, it does get skin-like sensation, um, but not erogenous sensation. It also doesn't have a urethra at the first making of it. So again, that's a groin. It's rolled up and then attached to the pubis. And over a course of many months, slowly, 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 that pedicle, that base where the blood supply gets cut, and then the penis dangles. This is an example of someone that's far more, far far advanced in like the staging because you can see that the glands has already been created. They have testicular implants. Um, so this is an example of a groin flap, and I show one of the complications. It can get wound issues, wound healing issues. This patient had a bit of necrosis at the very, very tip of the groin flap, but it went on to heal without any major surgery, and actually kind of worked out because it ended up looking like the meatus of the urethra with a little divot there. Eventually, this patient ended up getting a urethral reconstruction. ALT flaps is another way of doing um, a pedicled flap. It comes from the outer thigh. But the one thing about the ALT is that certainly for me in most centers is that there are very specific qualifications for this, meaning that patients' thighs have to be very, very thin in order for me to do this, especially if I'm doing a urethra at the same time. And it's known to have, it's known to create very large, but like impossibly large penises. And so, I think that's one of the disadvantages if it's done on patients that have a bit thicker tissue and then they end up getting a urethra added to it. They can be quite thick, like soda can thick. I've seen it even bigger than that. So but the donor site is more easily hidden. It is a big patch. There is one center here where they do, I think, tissue expanders to eventually get rid of that scar or minimize it. You can't ever get rid of it. But to be able to decrease the size of that scar. This is one of the ALT flaps I did right after surgery. It looks a bit bruised, but it ended up making it. The patient, you can see the scar on the thigh there. The patient eventually ended up coming back and we put a urethra in there. That's what the scar looks like. Okay, finishing with radioform phalloplasty, it's considered kind of like the ideal flap to create a penis because it's typically thin. It's pretty like it's easy to work with because it folds really easily. You can do a tube within a tube design, meaning make the urethra and the penis with it. It is a microsurgical procedure, but it carries a nerve with it. It carries a cutaneous nerve of the arm, and I connected to a dorsal clitoral nerve. There's usually paired nerves there. And so I make that connection such that the patient's potentially, nothing is ever a guarantee, but potentially could end up having erogenous sensation along parts of the penis, or even like most of it. I have had patients report being orgasmic through their penis, even if I'm using radioform for just a urethral reconstruction. Um, but to be honest, it's definitely not 100%. I'd say 50-50 that by a year or 2 years, patients get sensation enough that they are orgasmic through it, through the penis itself. The detractor is that the arm has a very, that's me making one. The bad thing is that the arm has a very large scar that has to be skin grafted with a split thickness skin graft, not a full thickness skin graft because the area is so large. But we do order silicone lined compression sleeves for the patients to help make that scar as best as possible. Glansplasty. This patient had the phalloplasty and then came back and had the shaping of the tip. Just a picture of what the donor site could look like. I think this one is fairly typical. And patients can can easily explain it away as I had an industrial accident or I had a burn injury, something like that. Um, you know, another example of, what the skin can look like. Just more pictures of what this looks like. Afterwards, if the insurance approves it, I put a wound vac dressing over the donor site. Because I take a cutaneous nerve, people are concerned, patients are concerned, is my hand going to be numb? Does this affect am I going to get carpal tunnel? It's not that nerve. That nerve is not harmed or shouldn't be harmed in doing a radioform. But that little marked area on the base of the thumb, that was the only part of their hand that they reported having numbness in. So pretty small. And over time, it's probably permanently numb, but sometimes the nerves grow around the very, very edge. Um, and patients end up doing fine with it. I can also do a urethra only microsurgical flap for patients who have had a phalloplasty without a urethra, whether it's an ALT or a groin flap, or they had a phalloplasty and a failed urethral flap. I can make them one with the forearm as long as their forearm, one of their forearms isn't already used up for other procedures or from a complication or something like that. Okay. So more pictures of this. Um, yeah, there are variations on how I do the microsurgical urethra flap for those who already have an existing phallus that doesn't have a urethra. And so sometimes I'll add a patch of skin from the urethra portion and externalize it. You can see there's like a patch of skin um, in this picture, so that when the nerve does grow, the patient will have sensation through the urethra, which is on the inside of the penis, but also potentially on the outside of their penis through this patch that was taken from the forearm. So same thing with complications. Urological complications, I'd say are probably the most common, fistula, stricture, and that the nerve doesn't, may or may not grow. Like I said, honestly, maybe 50-50. And I've talked to other surgeons too. I do require, I do require electrolysis because this is a picture, it's not my patient. It's one of Dr. Meltzer's patients in Arizona who either had bad electrolysis done or didn't do it long enough. But once it was created into a penis with a urethra, the hair grew back in the urethra, and this is what it looks like on the inside. So, oh, and this is one of my patients where I pulled out a hair plug from the urethra after their surgery at a different stage. So yeah, donor sites for the urethra reconstruction only. It's much, much smaller, as you can tell from these pictures. And patients tend to accept that much, much better than the full radio forearm phalloplasty. Erectile device, this is the last part of it. There's different types of devices. I use a hydraulic one, meaning it has a pump and it's fluid driven. That's the one I use. And they work, but it's like what I call the cherry on top for those who want to go through this pathway of the flow chart to get to the erectile device. But everything has its pros and cons. They can fail. I actually just saw someone with a failed pump. I didn't put it in, but they have one. So I'm going to replace it at some point. And I also, not this year, but the beginning of last year, someone came in with an infected a different type of erectile device, and it was pussing out of the tip and the base as well. So those are potential complications, device failure, infection, but otherwise, it works. Oh, this is a picture of someone that had it's hard to see, but they're infected. So let's see. Yeah, that's it. Gender surgery is very complex, especially when it involves microsurgery or all these sort of not moving parts, but like all these different components, depending on each individual's pathway through this flow chart of where they want to be. So again, with transmasculine bottom surgery, it can be very, very specific. So make sure that your surgeons talk to you about all of these things instead of like, oh yeah, we can make you a penis. And sort of, I don't know that anybody does that, but they should present you with all of these options so that you really have time to consider these things. And there may be something along that path that you don't like, and it's okay. Or things that you want to stage a certain way. Um, so yeah,
Thank you
that's
so much, Dr. Lay, for sharing your knowledge and your expertise with us. Do we have any questions from the audience? You're welcome to put your questions in the chat, or you're also welcome to raise your hand and ask your questions out loud.
if there are questions that come out, will you read them to me?
I will, yeah. And you're welcome to stop sharing your screen if you'd like to.
Uh, Maybe I need to.
There you go.
Where is the
Oh,
chat?
someone asked, would the alt phalloplasty need a vaginectomy?
Not necessarily. Again, it just depends on whether you are hoping to have urethral reconstruction. Remember, if I do a urethral lengthening, then I do require a vaginectomy. But if you don't and you just want an ALT phalloplasty, and it's just the phallus, you can put an erectile device in it. And once everything's healed, the penis will work, but there's just no urethra in it.
There's another question. I'm sorry, a person would like to ask, can a patient feel an erectile device after it's been implanted?
Yes. You mean I assume if they touch it, can they feel it? Yeah, they can feel it.
And another
Not a bad
question.
thing though. Just to be clear, it's not a bad thing.
Okay. And another question is it possible to use the calf as a donor site?
Well, it depends on what tissue you're talking about. If it's to obtain partial thickness skin to line, the forearm wound or the thigh wound, then sure. But in terms of like tissue, to make a penis or a urethra, I have not seen that described. I have done calf flaps for lower extremity reconstruction back, when I was doing training in plastic surgery. Um, but not that I know of for gender surgery. But it is a flap, so it's a good question.
Someone else asked, if the patient had scars, how would that affect a donor site in reconstruction?
It depends on what scars you're talking about and why the scar was created, right? So for example, if someone has had um, maybe a hernia operation or some sort of abdominal operation, I worry whether the blood vessels were damaged, or, through having that surgery, or was it a traumatic wound? Or is it simply cutting, like self-harm type of cutting? That usually doesn't keep someone from having surgery or using that patch of skin for a flap. But again, it just depends on what kind of scar you're talking about. But I do have to think about blood supply and that kind of thing, so that I don't just ignore the scar and go ahead and like make something out of it and have it go all wrong because things underneath it were injured or something like that.
We have a comment. Someone said, this is not a question, but I just want to say thank you. I'm in the process of starting RFF phalloplasty with Dr. Lay after undergoing UL metodioplasty with her. I actually had a surgery with her this morning. She's an amazing, amazing surgeon and person. Thank you, Dr. Lay. Truly, from the bottom of my heart, you've changed everything for me.
I know who that is.
Pretty specific information.
Should be recovering.
We're gonna assume that they were lying down as they type that.
Um, yeah, anything
Question for you,
else?
Dr. Lay.
Yeah.
Do you have much experience with uh v VPP, vaginal preserving phalloplasty? It's something I've heard of recently.
I I've had patients request it. I've had questions request not just vaginal preserving, but vulva preserving. And I don't know if they mean vulva preserving or just vaginal canal preserving.
Um,
But
I
anyway, but yes, you can have it done. It just depends on, again, which pathway, um, and whether it still comes back to, if you want urethral lengthening with me anyway, I do require the vaginectomy. And by extension, you would have to have had a hysterectomy. But no, you can have a penis, a full-size penis, or a metoidoplasty with scrotum and implants and everything, with the urethra and the vagina fully intact. And I have done that before for those that, again, choose that pathway.
okay, but the hysterectomy is a requirement.
With a vaginectomy, yes.
Okay. There's a question. Someone asked, would the donor site be able to be covered after the surgery with tattoos?
That's a very good question. And the answer is yes. Um, But the only disclaimer is that depending on how well the skin graft and the wound healed, it can be a little more difficult, um, to tattoo it maybe. But yes, that is possible. There's also ways of trying to improve upon the grafted area, especially if it divots down. And that's fat grafting, to kind of elevate it so it's not like a sunken wound. But again, that depends on what wound we're talking about, how that skin graft healed. But yes, you can tattoo over a patch of grafted skin. But again, it really depends on that quality of the scar, of this how the graft took.
And we have a question. Is there any way to repurpose the tissue from the G-spot?
That is another question that patients ask me, um, and I can't say that I know how to do that. So I guess I don't know. I'll just tell you. Sometimes patients do, in relation to, along that line of, um, with the G spot, sometimes people ask me if I preserve the periurethral glands. because they want to retain the ability to secrete. And the answer is yes, I do cut around it. Um, and it's something that's actually visible. You can actually see it. They're little pits all around the urethral meatus. And so I do basically, when I make the cut around the urethra to do like the extension and all of that, I make sure I go around it so that it's included in that cuff where I attach the extension tube. But the G spot, I don't know. Honestly, it's kind of a mystery to me, so I wouldn't even know where to look.
I have another question. Someone asked, do you intentionally excise Skene's glands for phalloplasty, or do you usually ask the patient what their preference is?
Um, well, those glands are, again, I preserve them.
Well, I don't see any further questions, but thank you so much for being here with, oh, sorry, we have another question. Do you need a complete hysterectomy for surgeries you need a hysterectomy for? So in other words, I guess, does the hysterectomy need to be a complete hysterectomy when it's done?
Uh, okay, no, because total hysterectomy means taking the ovaries, and the ovaries they they have no bearing on what I do, zero.
So it's
So
actually possible to leave the ovaries.
yeah, and that's a conversation between you and usually the gynecologist, whether you want to keep both, you want to keep one, or you want to take both. But the actual uterus, and I think when they take the uterus, I think the fallopian tubes go with it. Um, that's all I need is that the uterus is taken out before I do any urethral work in terms of lengthening it, because I do require the vaginectomy for that specifically, for the urethral lengthening.
Then I have a question myself. When you leave the ovaries, like, do they need to be kind of tied onto something, or would they like just fall around? I don't know much about the anatomy, to be honest.
I don't know. I think they're I don't think they just float around. I'm not a gynecologist, so I don't think they bounce around in there without I don't know, honestly. I I'm unfamiliar with that because I also don't do the hysterectomy.
Okay, someone commented that they heard from their partner that the ovaries just float around.
Okay.
Do we have any other questions?
It's a lot of information. Thank you. I just try to, I'm sorry I was late because I was on this other call. Um, but yeah, it's a lot of information. I'm working on improving that flow chart. Um, and I just gotta find time at some point where I'm gonna try to come up with a decision-making tool, kind of like not quite like an app, but a tool where, it'll help you like go through all the different options, and then at the end you get a summary of what like the summary of the procedures and the path that you want to go with. Um, and so I'm kind of working on that. I started on it actually. I think the transmasculine and masculine non-binary patients would really like something like that. My daughter is in medical school and she's along with a different office. She's helping them develop a tool for top surgery, actually. So she presented it at WPATH in Portugal this last year, and um, she refined it. She just sent me the new edition of it. So I'd like to see something like that, but for bottom surgery.
Yeah, and I would love to see that too. Those
It's
tools
a
sound really
flow chart.
awesome.
Yeah, it's a flow chart, but simplified. Um, yeah.
All right. Well, thank you so much for being here today. We really were honored to have you here with us, Dr. Lay. I know how busy and valuable your time is. So thank you so much for coming. And you're welcome to stick around for the panel discussion, or you can take off. I know you're really busy, so I don't want you to feel like you have to attend the whole thing. But thank you so much for being here with us today.
Yes, thank you. Thank you so much. I hope you you know, got some good info and ask the hard questions when you go and see more than one surgeon. Okay.
Thank you. Have a great evening. All right. We are now going to open up to um, well, actually, I'm going to start introducing our panelists. So now, in a random order, I'm going to introduce tonight's panelists. Today, we have two panelists with us. We have Carlos Lopez. Carlos is a board member of Trans Emotion, which is, as I explained earlier, we are a nonprofit serving the trans population of California Central Valley. Carlos is also a board member of Quest House Community Healing, a post-op recovery home in the Bay Area for trans masculine people undergoing bottom surgery. He is also a caregiver with T4T Caregiving, a grassroots collective of post-op traveling caregivers. Reg started his medical transition in 2006, which is the same year he founded a peer support group, Trans Guys, in Portland, Oregon, a group that is still active. During the pandemic, he created and facilitated a monthly online group, Alt Dick Story Share, for people who are interested, planning, undergoing, or had completed alt phalloplasty. He is currently one of the facilitators for Fully Pickled, an online post-op lower surgery peer support group. So welcome. Uh, welcome to the stage, Carlos and Reg. Thank you for being here with us today. So I'm going to ask four scripted questions. Our panelists will have about up to 5 minutes each to respond to each of the questions. And then after that, we're going to open back up to live Q&A from the audience. So the first question I have for the two of you is, what type of bottom surgery did you have, and why did you choose that procedure?
You want to go first, Reg?
Yeah, sure. I had ALT phalloplasty done back in December of 2019, so literally a month before the pandemic started. And I have actually started researching bottom surgery, I would say starting 2008, when back in the day when there was like Yahoo email listserv, and that was, this is before social media. Uh, and so it took me years to decide on which procedure. And so initially it was, do I want meta or phalloplasty, right? So those are the two binary. And then I decided, okay, I want to go with phalloplasty because eventually I'll probably want phalloplasty. Um, but then it took me about 2 years really to distill it down to either RFF or ALT. And the re the reason why I ended up with ALT was because I had unusually thin skin on my forearm, so I don't have a lot of fat on my forearm, and so one of my fears was having a very skinny girth, small girth on around and it's possible to reduce your girth, but it's much harder and challenging or almost impossible to gain girth. And I wasn't a fan of having a visible scar on my arm. And I just had this kind of fear that something would happen to my arm and I wouldn't be able to use. So anyway, I decided on ALT and it actually turned out to be the better option. In fact, unlike what Dr. Lay was talking about ALT, which is unusually, it's common to have thick girth, but I ended up with pretty under the average, even RFF consideration for that girth size. So if uh yeah, it was the best choice for my body, my own body type. Yeah.
Hmm. Um, I guess so. I had RFF phalloplasty back in 2022, June 2022. So here's my arm scar actually. Um, but I think well I've always had like really thick thighs. Like I've always carried my weight there. And even like after being on, hormones for a while, it still kind of stayed that way. And like it's kind of I think like I figured like okay, this is just like, you know, it's if I go with that way, like I'm gonna have to go with debulking probably maybe, one or two times. And at that point I was like really well, I mean we're all really like, like when we're in the space where we really need surgery and we're planning for it, like, a lot of us want it done as soon as possible. But for me, like I also was kind of like, okay, I want to get at least stage 1 done before I'm off my mom's health insurance because she had really good insurance and really good coverage. And I was in network with the surgeon I was really wanting to go to, which is Dr. Chen, and the Bunkie Clinic in San Francisco. So I was just kind of like, I had really thick thighs and I wanted to like get a lot of the surgeries done before I was off my mom's insurance and just kind of, like they kind of like lined up for me. And like I also kind of was okay, with the arm scar and like with that donor site. Like I didn't really have any like problems, I guess, with it. I didn't have any like I figured, like maybe at some point if the scar bothers me, then I'll get it tattooed later, which, at some point I'll do. I just don't have the money or the time right now. Um, but yeah, that's kind of like, the time consideration and like insurance and just kind of like, those were the two biggest influences I think on me choosing RFF.
Thank you for sharing. Our next question is, what was your recovery process like?
I guess so um I'd say first, I mean like I've had like so stage 1, at least for the way that Dr. Chen does it, and some of these like, centers do it differently, the way that they stage things. So the way that he does it a lot of the time is he'll do like he'll make your penis, and then if you want scrotoplasty, like he'll do that at the same time. And then if you want urethral lengthening, he'll create the urethra and like connect it. And then also he'll do, the vaginectomy. So he'll kind of do like they call it like all in one staging. So that's what I had done. And so because of that, like it was, it's kind of a lot to deal with at once, because it's you got the donor site, and then you've got, like you're also dealing with, your like with especially in the early stages of healing too, like especially in the hospital, like they have your penis kind of like propped up. It has to be at a certain angle to like maintain the blood flow and stuff. So you're always just kind of like, I'm like you're paranoid about that. And so there's a lot going on. So it was really draining. It was really difficult. And for me, it was also really painful because I had like some weird like allergies and tolerances to pain meds, which I didn't know about until I had surgery. And then I was like, because they'll hook you up to like Dilaudid or like those really high painkillers. And so like they give you a little button, and so then I would like press a button, like nothing would happen. And I'm like, is this like what's going on? Like, why is it not working? So then they switched me to like oral, like and it's tramadol, I think, is the one that Dr. Chen uses. So they switched me to that, and then like after that, I was like, oh, okay, this is what it was supposed to feel like, no pain. Um, but yeah, it's very like yeah, the stage 1 is like there's a lot going on, like there's a lot of things to be anxious and worried about, like so it was really difficult for me, but I actually had a caregiver from T for T caregiving. So that was really helpful. And they also happened to be, they were actually one of my friends prior, so like it worked out that way. Um, but yeah, just kind of like in especially that first month, I was really leaning on like my caregiver and like I had like an online community, like, there are like Reddit and Facebook groups that have like popped up to provide support, like so there's a lot of spaces like that online. So I was really leaning on those, and it's just nice to be like in those communities when you're really going through it. But the other stages I needed like a lot less support for. Like I got glanceplasty later on. Well, I had it done twice technically. They had to redo it. Um, and then I had testicular implants also with each of those. So in total, I've had like three surgeries. But yeah, like the later ones where it's like implants or like glanceplasty, like those are like a lot easier emotionally. I mean, they're still like it's still hard, to have surgery and to like see your skin, like kind of roughed up and, bruised and all that. But like yeah, emotionally like it was a lot easier. Like I crashed with a friend in the Bay Area and like she gave me a ride and like yeah, I didn't need that like intense support like I did the first time. So
Thank you for sharing. I'm so done with surgeries. I mean, kudos to you too, because wow. I know there's a lot of surgeries that go into having phalloplasty or any type of bottom surgery. So you got through it though. And Reg, I'd like to hear from you.
Yeah, so I just want to also preface it for those of you who are in the early stage or researching that depending on which surgical team you go to, they stage out. And by the way, I'm assuming we're talking about phalloplasty only because that's our experience. The way each surgical team stages out procedure is different. So whenever you hear people say, my first stage, the better question to ask is, what does your surgical team do in first stage versus second stage? Because I went to OHSU with Dr. Burley in Portland, Oregon. He stages out ALT differently than RFF. And then if you compare that staging with Dr. Chen's team or other teams, you're going to hear different things, right? So I just want to put out there if you're in the research mode that just because we say this is first stage, don't expect that with your surgical team. But with that said, my recovery, I mean, it started in 2019, end of 2019, and it's what is it, almost 5.5 years ago. So I completed all the stages. So got all this stuff done, right? So that includes first stage is the creation of the phallus, the penis, and just letting that heal. And the second stage was vaginectomy, um, uh, what do you call it? Scrotoplasty, um, urethra lengthening. So putting in stuff so I could stand to pee. And so that was second stage. And then third stage, I had some, I wouldn't call it complications, but things that needed to be done before the final like implant stage. And so I can go into a little bit later because anyway, yeah. So the first two stages were pretty invasive and just the creation of phallus and nerve hookup, right? Because as the surgeon talked about, you're placing an entire one part of your body and attaching it to your groin. So there's a lot of like healing work. I was able to heal in my parents' home, and I coordinated friends to come by to help and whatnot. So looking back, it was hard, but it wasn't. And then, but so second stage, vaginectomy and scrotoplasty and urethral lengthening, that to me was a bit more challenging and more physically painful because vaginectomy, they basically like suture up your stuff and um, yeah. So the other stuff, so I had some kind of I didn't like the way my glanceplasty, so the way the head of the penis like was created, it kind of flattened out. So I wanted a revision of that, but I also wanted to make sure that I had testicular implants. So I had those two things done, but I went to Dr. Chen, not Dr. Burley. And so that's another thing I want to say is you might start with a surgical team because insurance reasons or whatever your preference, but also when it comes to more elective procedures like glansplasty or scleroplasty or suturing out your implants, testicular implants, those aren't so tedious or draining that you can really get it and places that as long as the surgeon's okay with it. So I like the way Dr. Chen did glansplasty, technique wise and style wise, and so I got my revision done by him, and then I had the testicular implants put in by him, but I also had erosion. So that one of the testicular implant eroded. And so I had to take that out during that time. I also had this thing where I was able to excise the scar on my leg, the donor leg, because it's very big. But there, I don't know if some of you know, but you can minimize a scar after surgery. So I had that done while I was waiting for the testicular implant erosion to heal. So the reason I'm saying it in that way is that it's healthy to expect some kind of complications or a pause in your process, but utilize that as an opportunity to do other things, so that you don't feel like you're just twiddling your thumb waiting for that next thing. And so during that time, I had to wait for these things to heal. I also got medical tattooing on my penis, which was, I would say, the most gender affirming experience because that's when I finally could match in my mind, oh, this is my penis, because the color, it just felt like it was mine. And so all I have to say, it was a long journey, and I finished the erectile device procedure in 2023, I want to say. So it took good 4 years, but I paced myself. So it's possible to do all of that in I think 2 years, but I also wanted to make sure that my scrotum stretched so I could put bigger implants. So the whole recovery, I don't say it's not like top surgery where you get the surgery and you recover, right? There's so many options to get after phalloplasty because it just means you create your dick. And then after that, everything else is almost optional, if you will. So the journey could last forever, or not forever, I'm sorry, longer than you expect. But for me, I would say from start to finish it was about 4 years.
Wow. Kind of makes me think of my top surgery, which normally is supposed to be like one and done, but for me, it was actually three surgeries over the course of a year and a half because of just complications. But yeah, so our next question is, what side effects or recovery hurdles have you experienced in the long term or in the short term?
Um,
Arian, can I ask when you say side effects, do you mean like things that we didn't expect?
Just anything, yeah, just anything that you didn't expect, or something that you don't like, or something that you thought would work out but didn't work out, or something that went wrong, or any sort of like complication that came up later on.
um, I don't know. I don't. I mean, for me, like I didn't have any urethral complications at all, and I still haven't, like, knock on wood that I don't get a stricture because I said that. Um, but I don't know. I think just like my glands flattening, like because it flattened completely the first time, and then I had it done again, and it flattened a little bit. It's still not as prominent as I wish it was. So in that respect, I'm like, dang, I wish it would have been more, more prominent. But like it's still not enough for me to go back and be like, all right, let's do this a third time. Like I've told myself like maybe I'll do that in like 10 years or something. It's like one of those things where it's like it bothers me a little bit, but like in the big picture of things, like it's not like I don't know, like it's like doable. It's like I can live with it. It's like in the grand scheme of things, like it doesn't bother me like that much. But that's really about it, honestly. Like, and I'm still kind of weighing like if I want an erectile device, which I think like probably that's something I'm gonna revisit, in a few years, like when things are a little bit more stable for me again. Because then, it's like, it's another surgery, more money, more time off kind of thing. But yeah, again, these things are like not, it's like not enough for me to be like, I want it done like right now. Like that's something that I'm like, I'm gonna revisit this later.
Yeah, and y'all should just take whatever we're saying with grain of what is it? What's the saying? Grain of salt. Is that right? Am I saying it
Yeah,
right?
I
I'm
think
all
so.
switching it up. Anyway, because there's such a huge array of experiences around complications, and I'm probably saying all of this to contextualize our experience from the larger experience because I run these support groups and I hear so many different stories and varieties. So I guess I want y'all to whoever's listening to this to filter it with that lens. For me. I wouldn't call it side effects, but some complications I didn't expect. For me, it was also a very rare thing for ALT guys is I experienced some almost a permanent numbness down. It's a very small strip of area along the shin bone of my donor site leg. So it feels like your leg fell asleep. It's just never waking up. So it doesn't bother me functionally, but I think it was a nerve damage. And my guess was that during surgery, first stage, the nerve hookup when they were creating the phallus, um, my surgeon said he had a really hard time searching for some of my nerves. And so the surgery actually went extra 2 hours. And so me being in that position, laid out flat for 14 hours, I think it may have pinched my nerves. And so this is a very rare thing that most people wouldn't experience, but I experienced. But on the flip side, I had no urethral lengthening complication, UL related complication, and that is one of the most common complications. So I feel really grateful for that. And also in terms of sensation, I have full sensation all around my penis, which is also, not common. Some guys have it partially, or some people just don't feel it. So in the grand scheme of things, there are things that I experience that's kind of uncommon, kind of sucks in some ways, but on the flip side, I feel really grateful because I started this journey with my th mid 30s. And I can tell you the younger you are, your body will heal better, generally speaking. So if you do have the opportunity, I would not push it off for 5, 10, 20 years. Your body, definitely there's definitely cell degeneration happening as you age. So in terms of recovery, I think the younger you are, just better in general. But with that said, I will say there's some guys who because to prepare for surgery, they got in the best shape of their life. And even though they were older, it actually worked out better for them. So, it really depends. But I think those are some unforeseen, unexpected hurdles that I experienced. One maybe thing I might add, I did mention I had serial excision done on my leg scar to minimize the scar of my leg, donor leg. After I had that done, I actually experienced more numbness around my leg overall. So that's when I was like, oh no, I'm not doing this anymore. Because the plan was I would by like each procedure, I would just minimize scar till to a point that it became like a strip. But when I minimize it like maybe an inch, after that surgery, I noticed more numbness. So I think at that point I was like, okay, it's not worth aesthetically minimizing my scar to, in exchange for loss of sensation or so I actually got tattooed over on my scar and it looks really great. And it camouflages really well. And so this pictures that I think Dr. Lay showed, those are sort of a little tricky. And I'm not a big fan of surgery pictures by surgeons because they're so raw that if y'all are just some of you are starting this journey, I would recommend looking at post-op guys like at least 2, 3 years down the road. It looks very different. Um, and so that there's actually a lot of like misunderstanding and fallacies and stereotypes about what phalloplasty dicks look like because this pictures they see are what Dr. Lay showed, and that's not and not to put throw shade at those pictures, Uh, but I don't think it represents what's out there in terms of guys who've had medical tattooing done, right? Like had other procedures that the doctors don't do because that's not the nature of what they do. So I would invite people to really do their due diligence to research post-op pictures so that they're not like scared by all these side effects or like complications, all the surgical raw like pictures and basically draw this conclusion that phalloplastic dicks look XYZ, because that also hurts this community. That's why a lot of guys I know don't want to share because of all the bullshit like comments people put up. And those are the people who only look at like post-op really raw pictures and then they make judgments. So anyway, that's my little rant, but in terms of complications, don't get too scared if you're looking at surgeons' pictures. I would look into it a little bit more.
Thank you. Yeah, and if anyone's wondering where to find those kind of pictures, I use Transbucket. I can't remember if it's transbucket.com or .net, but it's a good resource for trans people, where you can find pictures, not just fresh pictures like what surgeons will show you, but also pictures like later on down the line.
And Reddit has really good pictures, as well as there's a lot of Facebook groups for lower surgery. So I would join those. And this is if you are seriously pursuing it yourself, because some of these groups are closed for only those people who are pursuing it, not for random like lookers.
And we have one more question, and I also want to apologize to the audience that we don't have a metodioplasty uh, panelist here with us today. We did invite one, but they weren't able to make it. Okay, so our last question is, what benefits have you experienced since recovering from your surgery of choice? I guess I should say since recovering from your series of surgeries in most cases.
Um, I mean, I guess like I mean also what you were saying, Reg, about like tattooing, like because I had one session of tattooing done about a year ago, year and a half ago, and it was like me and the artist, I don't know if there was some sort of lack of communication or some, like what I wanted and then what I ended up with was not at all like, they didn't really overlap that much. So I was like still kind of in that in between space where I was like, okay, like this is my dick, but I'm not like it doesn't feel it doesn't I'm not really connecting with it fully. But then I had another tattooing session with somebody else back in January. Yeah, January. Wait, December, January. But it was a couple months ago. Um, and it was like I don't know, like I think we communicated better and like I don't know, I think he took some of my feedback more and also like him knowing that I came from somebody else too, maybe that kind of but anyways, like he like it was crazy. Like it was like he read my mind. Like so now, I look at it and it matches like the color of my skin. Like I don't know, like he did a really good job and like it's been like I don't know, it's just crazy to like I can stand in a full length mirror and I look at myself and I'm like this is like, this is perfect. This is amazing. Like, it feels like me. And just kind of I'm like my daily life, using urinals like, every day at school and work and whatnot. And like never, I used to work as an archaeologist, like out in the field. Um, and so like a lot of times I would have to pee outside and like by my car and stuff. And so I did have an STP, not like the ones you packed, but I had the Easy Pee, I think, or what's is that what it's called? I already forgot. But it's the little plastic one. It's like a little funnel. And so I would like carry it in a little baggie and I like put it in my vest and stuff. And so I was always like scared, that someone would like see me doing that, or, like come up to me or, open the door and like I was like there in the porta potty. Um, and so that was always just like, I just always had that fear. And then, then I had surgery and then I was just like peeing all over the place and like I'm like, go ahead and walk up to me, I don't care. Um so it's kind of like, no longer having that fear, especially now that I'm like two tattoo sessions in, like especially I'm like, go ahead and look, I don't care. Um, but yeah, just kind of like, like just the um like, just kind of realizing, I mean, like especially the months leading up to stage one, like, I just had so much dysphoria around like, just everything about my, genitalia like beforehand. Like, I don't know, like I was just always aware of it, like 24/7, like just, it just drove me crazy. And then, being on the other side of that where that's no longer like present, like, it's just I don't know, like I was just so like struck at how like oh like I can think a little clearer now. Like I don't know, like I just don't have that like in the back of my mind all the time. Like I'm like, at peace. I can finally do a lot of the things that I've been wanting to do. Like I've been doing Mexican folk dancing, I've been doing folklorico because like I mean, and again it's like obviously like you don't need a dick to be doing that kind of stuff, but like for me like it's just my previous situation, like the dysphoria was so bad that I couldn't even do a lot of that kind of like workouts and like movements and like be in those kinds of situations. But like yeah, now I'm doing all kinds of like I'm doing that. Like, I'm gonna probably take some swimming classes. I'm gonna try to learn how to surf. There's just like all kinds of things that I'm like finally able to do. So,
That's awesome. And in regards to your tattoo experience, I just want to say, as someone who has a lot of tattoos, your first experience is actually my first experience, where like most of what's on here was not what I asked for. Sometimes they just do things like this guy like did a bunch of stuff where I was like, I didn't want that, but he just did it without even asking, just like would do stuff. So unfortunately, you really have to be careful who you get a tattoo from. Like, talk to the people that have had tattoos from that person. Don't just go like, oh, I love their art, I'm just gonna go in like I did. Like, go talk to people who had tattoos from that person and see how receptive they are to your feedback. Like, ask them how receptive the tattoo artist is to feedback, or if they're the kind who will just do whatever they think you want without really consulting you. I think that's kind of really important, especially if you're getting something as special as your phalloplasty tattooed. You really want an artist who's going to actually do what you want and what you envisioned, and not one who's just going to go off on their own script. Reg, what would you like to tell us about the benefits and the great things you've experienced after having your surgeries?
Yeah, I would even just to piggyback on what you said, I would say that self-advocacy is an important skill set going into surgery, just because um, assuming you're not just doing simple meta or simple just phalloplasty, you're going to see a lot of providers, and it's important that you feel confident asking for what you need at every stage. And even if it means, hey, can you give me an extra pillow under my leg? So it's not just when you're talking to a tattoo artist and then describing what you want. It's really just how we navigate the healthcare system. So I can't stress enough how important that is a skill set. And if you lack confidence, this is where having a buddy or circle of friends, supportive people around you can really help, because you don't want to regret because you decided, oh, I don't want to be inconvenient to that surgeon or that nurse, and then end up with some kind of whatever. So this is your body, it's about your health. So I want to emphasize that. In terms of benefit, very similar to Carlos in terms of my dysphoria, it's almost all of it is gone. I mean, there's a couple of things, but those are things that I just, you know, unless you're cis, you're just not a cis guy, you're just not gonna have. But my ability to just not cover myself up, even when I'm alone. I used to like cover myself even when I was home alone and coming out of the shower when I knew nobody would see me. I would still could not stand just like being naked in my body. And I've been going to like nude beaches and just like going to the gym just to take like public showers and then not feel, like and being able to pee anywhere, like that's amazing. Just basic shit that I think a lot of cis guys took for granted. I'm kind of discovering on my own. So it's been such a joy at every moment. But going back, what was really transformational for me wasn't the first stage when I saw my penis. It was more of a sense of relief. It's like, oh, okay, I got done and there was no big complication. But it at that stage, I didn't feel connected to my penis because it just was like a big tube attached to me, right? Second procedure, it got a little bit better, but it was so raw that I'm like, oh, I just want to make sure my body's healed. So I still wasn't connecting. The next couple of procedures were more elective, meaning like revising my glands, getting medical tattooing done, right? That's when I started, oh my God, this is my body. And I started like connecting with my body and allowing that neurological, like neural connection to get strengthened. So the benefit has been embodiment in general, right? Like living in my body for 3 decades where I would dissociate from my own sanity and having to rewire my brain and rewire my just connection to myself and how much joy and room that allowed me to build relationship with other people without hesitation. That is not something I thought about before surgery. So close to what Carlos said, um, I didn't really hesitate to like grapple with other men, because I would, always pack and stuff and I would always be conscious, oh my God, are they gonna feel that this is not real? Like I would have do all this mental gymnastic thinking about what other people might perceive. I don't have that, right? So I could connect with men, I could socialize with men without that hesitation. And then so it's just such a huge mental load off on a day-to-day basis. Uh, so yeah, I can't stress how important this was for my life and my body. And it's not for everyone though, right? Not everyone experienced the same level of dysphoria that I had, particularly around my genitalia. So I don't want to say all this to say that it's the right thing to do for all trans people, right? Because there's some trans people that have like no problem with their genitalia. If that's the case, just live your life, love your body, and just keep on. But for me, no, like that, I was one of those people where if bad things happen and I died on the table, I would have been like, well, I guess maybe another lifetime, right? Because for me, it was really hard for me to just try to imagine my future being disembodied. So for someone like me, it was totally worth it.
Well, thank you both of you for answering our scripted questions. We are now going to open up to questions from the audience. And audience, please remember to be respectful of our panelists and mindful of others when phrasing your questions. To ask a question, you can either raise your hand and I will unmute you, or you can ask your question in the chat and I can voice it for you. And you can remain anonymous to everybody by directing your question to me specifically by changing the to area from the word everyone to Ariane Reed so that only I can see your question. And of course, any transphobic comments or questions, obviously intended to be transphobic, will be ignored. So I am going to ask a question that we actually had during the um, discussion. So our first question is, not to be too invasive, but in terms of a vaginectomy, how far slash deep was it? And you don't have to answer this.
Like a surgeon's question because we don't really know. All we know is like it got sewed up. Like I don't know.
It's just not there anymore.
No,
Yeah,
it's a
like it's
perineum
just
now. Yeah.
like it's flat. It's it's like a taint.
Yeah, it's just like a cis guy's like perineum area. Um, yeah.
We have a question. What was the name of that support group that Reg leads? And is it
Yeah,
still active?
Yeah, it's still active. We meet every other month. It's called Fully Pickled, and it's only for those who have had at least one or more post lower surgery procedure. So that doesn't include just hysterectomy. It includes whether you got, maybe meta or fallow, it doesn't matter, but it's not necessarily for pre folks. There's a lot of online resources and support groups for those folks, but this is a particular space. So if you're interested, I think let me see what's best. Let me look up the email. I know they just changed it because I co-facilitate with a few other guys. So I'll put in the chat in just a few minutes.
Does anyone else have any questions? Well, I have a question for you all. How many surgeries have you had to date?
um, I had yeah, I mean in terms of fallow, yeah, so I had my stage one again, which was kind of a lot going on there. And then it wasn't a surgery, it was more of a procedure. I had like a little bit of what's it called? Like I think it's called granulation tissue. So Dr. Chen basically like went in there with he went in my urethra with the camera and like kind of like I think he cauterized it and then so it was not really I would not call that a surgery. I mean it was just kind of like I was under for like an hour maybe even less than that. Um so that's like a surgery procedure, and then I had glansplasty with small testicular implants, and then literally a year later, then I had glansplasty again with medium testicular implants. So that's kind of so it's like three surgeries and then like one procedure.
What about you, Reg?
Oh God, there's a lot. So obviously the first two surgeries were procedures, stages were most invasive because I had a lot done, right? After second stage, I had glansplasty revision and testicular implants. So that was third procedure. Fourth one was the erosion. One of the testicular implant came out, so I had to take that out. And then the next surgery was replacement of that testicular implant. So I had to actually wait. Once they took the implant out, I had to wait 6 months and then have another procedure to get the implant replaced. And part of my reason for that was I didn't have a lot of scrotal tissue, and in order for me to like have bigger balls, which is what I wanted, I needed to let that implant just sit there and just let it kind of stretch my tissue over time. And so while I was waiting for that, that's when I also had the serial excision done of the scar tissue on my leg done while I was waiting for that, right? So I don't know, that's like five procedures there. And then I came back um to get scrotal revision done, meaning my scrotal tissue, the way it was created, it kind of created a W, and I kind of wanted like one sac. And so I had to get that minor procedure. And then I waited 6 months, and then I finally had erectile device put in. And when I did that, they upsized my testicular implant, and that was the last procedure. So there's a lot. I mean, I think in total maybe like seven. I don't know, but again, after second stage, the other stages were very small, shorter procedures, probably less than a couple of hours or whatnot. And then I had like medical tattooing done several times on my penis. Yeah.
Thank you. And we have another question. Is penetration possible without an erectile device?
Yeah, I think it depends on your body. So one of the you can call it benefit of ALT is that the nature of the skin is a bit thicker. So versus like more soft compared to RFF, forearm skin. And so I've heard of more folks with ALT being able to penetrate with just using condom or Coban and then putting condom over. And in fact, I did that before I had the rectal device put in, and I can. Um, or some guys like their dick is just kind of more dense, if you will, and because they're girthy, so they could penetrate without any assistance. For others, they can't just because their skin won't allow, their body won't allow. And there are some devices out there. A later, what are the other ones, Carlos? I mean, I know.
Yeah, I had later, which it's funny, I got like one of my friends was like, "Here, do you want an later?" Like, but it's been specifically made for someone else, so it may not fit you. So it did not fit me, so I passed it on. Um, but yeah, there's like the later, there's like the stays hard, and then like there's like, a bunch of like silicone sleeves that are like, you kind of just like, use some lube and you kind of like fit it in there, which I have a couple like that I've bought just in case kind of situation. Um, but yeah, like that's kind of like it's like you have those devices or you have like the silicone sleeves or you have like the Coban wrap and condom, or some people don't need any of those at all.
Does anyone have any other questions for our panelists?
Oh, I also put in the chat the form to fill out if you're interested in joining Fully Pickled, because they just switched platform from like I think Google Group to some other site. So yeah.
We have a comment that one of our participants is super grateful to you guys.
Yeah, this is a long and hard journey. So anyone who is feeling confused and just frustrated or just feeling down, it's all part of the process. And one thing I would emphasize is like have practice that will help your mental well-being, mental strength, meditation, centering practices, because there's gonna be a lot of times where you can't move or your body won't do the things that you want. And instead of being down on during that time, think of other ways to utilize that time. And, because I think I've heard so many people being depressed. And so I actually feel grateful that I started this in my 30s, because if I started in my 20s, I would have been a wrecking ball. Like I probably would have spiraled mentally. So I can't stress how important it is to uh, have a great support system, maybe meditation practice or breathing practices. It's not just about your physical body, it's also your mental state.
Thank you,
Yeah.
Red.
Oh, I was just also gonna like add on that it's like, this is one of those things too that's like, I mean, yeah, it's like, it's like a marathon, not a sprint kind of situation, which, applies to like, medical transition as a whole. But like just kind of, um, yeah, like having those like mental health strategies kind of in place, having like creating like a good, support network, like just kind of like, you know, having, um, yeah, I mean, just kind of having a plan for like, okay, who am I going to turn to? Like, if, I'm just feeling really fucking awful and I need to vent to somebody, like having those supports in place was really helpful for me personally. Um, just because, like, you will have those moments where you're like, what the hell did I do? Like, what did I get myself into? And you just need to like talk to somebody who's not gonna be like, oh, well, why did you do this then? Like, are you regretting it kind of thing? Like, just finding those people that are just gonna have that, the listening ear, and they're not gonna be casting judgments and like, giving you a hard time. I think is especially helpful for me, just kind of like, not it's like it's already such a stigmatized surgery, not only like outside of the community, but like, in the community too. Like it still carries a lot of stigma. People like Reg was saying, like people still have these like ideas that it's like, it's not worth it and it's not good and like, all these myths that people still spout. So yeah, it's really important just to have those people that you can turn to in the times where you're like really going through it.
Yeah, so again, to stress the support groups, during all these times when I had one thing come up, my surgical team nurses weren't there answering all my questions every 2 seconds. So this is where I would go to like Facebook groups or all these other online groups and like, hey, did anyone experience X? And then someone would respond within an hour or within minutes, and I felt so much better. And so I think we need to rely on community because they also have firsthand experience. Surgeons are specializing in one particular area of your entire experience and not the entire recovery. And so I think sometimes we like put surgeons on pedestal and act like they know everything. And in some aspect, yes, they do because they're experts in what they do. In other aspects, they actually have no idea what you're talking about. And then they'll just like make shit up and then, or I don't know, make say something that's not necessarily true. And then it's really it's been really helpful to get other people's experiences, especially guys who have had surgeries with other surgeons, just to double check if your experience is a common thing, versus like oh no, you need to definitely seek out help right now because this is unique, right? Versus like, oh yeah, like that's sign of fistula, right? Like don't panic, like, and then you can kind of ease your mind during that recovery. So all those little things do matter, you know. So yeah, stay connected.
Thank you for the advice. I have another question since I don't see any questions in the chat. Um, I'm assuming you needed someone around to help you with the recovery. Like you wouldn't want to go try to go through this alone, right?
Yeah. I mean, I got super anal retentive and I created like spreadsheets. For first stage, I was like, okay, who's gonna bring me food the first week? And then I would reach out to friends, even if they sign up for 1 day out of the week, that was great, right? Or like, who's gonna drive me to and from the appointment? You know, like, uh, yeah, because I wanted to prepare for the worst case scenario. And so not that everyone has these options, but the more you can plan ahead, um, the better because there's so many uncertainties. So if you don't prepare, if you prepare 0%, you're gonna have 100% uncertainty, and that's gonna create anxiety for just anybody. But if you can, there are things that you can control, and then there's gonna be a lot of things you cannot, right? So the more we have ownership in the little things, logistical things, before we get ourselves into going under, I think that helps a lot. So I utilize friend circles, my family in particular, um, with boundaries. Obviously, I didn't want my sister, my mom to see like all my junk, right? So I would only ask them for certain things, but not others.
Yeah, like yeah, it's you really kind of like tap into kind of everybody. Like I was really happy that I had like over time, well, like because I was away for school for a while, but then I moved back to Fresno because of the pandemic. And but in that time, like I kind of developed, a good support network and like did my networking and made new friends and stuff. And so that really helped when I like and it also helped that I actually had some coworkers in the Bay Area already too. And so that, coworkers came by and dropped off like snacks for me and my caregiver. Like I got a ride from somebody that I know on Discord. Like so there's you kind of like you pull in, help from all these different sources. So it's like the more, spread out your network is, like the better. Because then, you just have like my mom ended up well, yeah, so she brought me to San Francisco. My dad was the one who like picked me up from San Francisco and brought me home. Like and then like yeah, I had old friends, I had coworkers, I had like acquaintances just like, coming by, bringing me stuff, sending me money on Venmo. Like so it's like yeah, it's like the more varied your support network is, like the better.
Along that line, in terms of support, I don't mean like only logistical too. So sometimes I would reach out to guys I know who had XYZ procedures done. And I would reach out to them and just say, hey, do you have a second for me to ask questions or do you think we can chat, right? So just being able to vent or ask questions with some of the guys who have had those procedures done, that was a huge support because mentally then I could kind of ease my mind while I'm like laying there recovering, right? So support also includes your mental well-being, in addition to all the logistical, like physical stuff.
Well, thank you both of you for answering all of our questions and providing us with all of this advice. We really appreciate you being here with us tonight. And to everyone else, please fill out the feedback survey. I have dropped the link in the chat a few times, and I will drop it again right now just in case you missed it. Your feedback really helps us figure out how to do better in the future. So I really appreciate all of you who complete this feedback form for us. It really helps us out. But yeah, that concludes our program tonight. So we're going to end about 18 minutes early. Thank you so much to everybody for coming, for being here with us today, and for being just a really kind audience. And I really want to thank Carlos, Reg, and Dr. Lay for having come here and providing us with all this expertise and experience and knowledge. So thank you so much, and have a great night, everyone.
Well.
Thank you all. Good night.
Bye.